Welcome, everybody, again to the third annual Alumni Speaker Series. Wanting to circle back to our origins for just a moment here. So we're in the third iteration of this, which started with the lovely Julia and Emma, who are on the top of my screen, who brought this idea of bringing kind of broader, diverse perspectives into our department and brought that idea to me after they had individual and group work. We brought that to Julie. She's really in tune with wanting to develop our alumni base. And so this speaker series was born and has been flourishing since then. So thank you for joining us either for the first time tonight or multiple times over time. So we will continue on with the speaker series. This year is really thinking about diverse and broad perspectives and bringing our phenomenal alumni in to connect with our current community of ICOT community members. So I am going to turn it on over to Julia today, who will be our moderator, and she will introduce our lovely alumni speaker, Danika, and kind of run through accessibility features and our agenda for tonight, and then we'll go ahead and get started. So Julia, on over to you, and thanks again, everyone, for joining.
Great. Thank you, Jenna. Hi, everyone. So happy that you all could make it tonight. So just before we start and hear from our amazing alum, I'll go over some access info real quick. So speaking on the closed captioning and live transcript, if you click on CC live transcript at the bottom of your Zoom window, which is next to the reactions button, you have two options. Option one is to show subtitle, which will make captioning appear at the bottom of the screen. To turn off closed captions, click on CC live transcript again, and then hide subtitle. Option two is to view full transcript, which will make the live transcript appear on the side of the Zoom window. If you want to simultaneously view the full transcript in the chat feature, go to the top of the live transcript window and click on the downward facing caret, aka Karen, and then pop out. You can move the live transcript anywhere around on your screen. With the chat feature, it is also at the bottom of the Zoom window. It is next to the participants button, and similar to the live transcript, if you click on the chat button and then the caret at the top of the chat window, you can choose to pop out the chat and move it around your screen. We welcome you to use the chat feature throughout the presentation, and then during the question and answer period, we will be fielding questions from the audience through video, audio, and chat. So just engage with the technology in whichever way feels best to you. This session will be recorded along with a full edited transcript and will be posted to the virtual OT site for current students, faculty, and staff to access. If you are not a current student, faculty, or staff and you want to access it, just contact one of us on the planning committee and we will figure out a way to get it to you. So without further ado, I will introduce the lovely Danika, who is here to speak to us tonight. So like Jenna said, tonight is our second speaker series for the third annual event. And we have the pleasure of hearing from Danika. So Danika Viola completed her Master's of Occupational Therapy in 2013 and now specializes in pelvic floor therapy. In 2020, Danika started Flourish Pelvic Health and Wellness, a private OT clinic. Her team of 3 specializes in pelvic health for women, pediatrics, and the transgender community, as well as general infant development and TOTS. She has also created a mentorship program for OTPs looking to begin or grow a pelvic health business and expand their clinical skills. Danika currently lives in Abington with her husband, 2 young sons, and 2 dogs. She loves hiking and camping, reading, swimming, strength training, and traveling. So Danika will start us off with an overview of her work, and then will be followed by a question and answer period where we will all have a chance to directly chat with her and ask any questions we may have. This is an informal event, so please engage with the technology in whichever way you'd like. And without further ado, I will turn it over to you, Danika, to get us started.
Yay, thank you so much, Julia. Can everyone, you don't hear me, right? I was having microphone issues before. Okay. So hey everyone, I'm Danika. I am, she just did a great job introducing me, so I don't really have much else to say on that. So basically, I just want to get started. Just give me 1 second to get some more. There you go. Okay, so I put together a little presentation because it helps keep me on track, because otherwise my ADHD brain likes to just go everywhere. This is exactly what she just said. So basically graduated in 2013. Before pelvic floor, I was working at a skilled nursing facility in inpatient acute rehab at University of Pennsylvania in pediatrics, both outpatient, early intervention, preschool age, as well as an acute rehab, like in a hospital. Started taking classes and working in pelvic floor in 2017. Currently 2 little ones, so they are about to be 2, and I have a 3-year-old. 2019 and 2020 babies, so you can imagine how tricky that was, on top of starting a business. And then another fun fact is that I actually became an elective below the knee amputee in 2014. So that was due to a car accident. So I also kind of, work a lot with the disability community because I'm one of them. So it's a pretty cool little niche I get to be in as well. A little club I get to be in. And one of the fun facts about me is that I've always enjoyed rebelling against systems, which kind of goes into how I got into pelvic floor therapy. So let's dive into, I know this is a lot of information and I will make this accessible to everyone because I'm not reading every single line on this, but I wanted you all to have the information of everything in this presentation. So what does pelvic floor dysfunction affect? Everything, truly everything. So it's basically a specialty that I kind of came across because my sister, who had a kid at 19, was leaking 5 years later. And I was like, well, that is strange. Like, you're 24 years old and you can't jump on a trampoline with your 5-year-old. That's really sad. Found out PTs could do it, pelvic floor therapy. And I thought, but isn't bowel and bladder OT? So then I decided I'm going to look into these classes, looked into the classes. Herman and Wallace Pelvic Rehabilitation Institute is kind of the big name for pelvic floor. And they teach classes to PTs, OTs, midwives, OBs, nurse practitioners. You basically have to have a master's degree in a field that can work with pelvic health. But that was my in. So I took Herman and Wallace level 1. It was a very PT minded course. Now there's more courses that are very OT based. But I was able to take that and basically apply it to my OT lens. So all of this is from the OTPF, right? So toileting and hygiene, social participation, sexual activity, child rearing, rest and sleep. If you're getting up 3 times a night to go pee, that is disrupting that, right? Health management, being able to lift heavy weights, being able to be active without peeing yourself or without having pelvic pain, play and leisure. So if you are playing with your child, you should be able to play with them in the full capacity that you want to. You should be able to participate in leisure activities like hiking or sitting, reading for 4 hours without having to pee constantly or without having issues with your pelvic floor. So then what do pelvic floor therapists treat? So as a pelvic OT, it's a little bit different. And honestly, it has been a huge growth in the past 5 years, which is amazing. I love seeing it. So we very often treat bladder health, right? So lots and lots of incontinence, lots of stress incontinence, urinary or urge incontinence, pain with peeing, all of these issues. Bowel health, lots of constipation, excessive diarrhea, hemorrhoids, things like that. We do a lot with the core. So we do a ton with diastasis recti abdominis, that abdominal separation that can happen during pregnancy. And women are really scared of that. And the truth is that it's not as scary as women think. And it's something that is totally blown out of proportion, and men can have it too. So it's not even a woman specific thing. It's just something that's kind of fear mongered around because women don't know enough about our bodies. Hernias, acid reflux, we can actually help with, core weakness, sexual health. So any sort of pain with sex is never normal. And that is something that we are taught, oh, just have a glass of wine and, relax, you'll be fine. That's not normal. We need to stop telling women that. Inability to or difficulty with orgasms, change in sexual function, performance, or satisfaction. Any of those kinds of changes, especially if it's an abrupt change, or if it's a change even due to something like pregnancy, postpartum, a surgery like a hysterectomy, anything like that. I mean, that is a huge deal. So we need to make sure that we are treating that. And then kind of the populations that we can work with, right, are women's health. That's the biggie. Honestly, every single woman benefits from pelvic floor therapy at some point in their life. So any of the chronic conditions that we can have, endometriosis, PCOS, scar tissues, anything like that, pudendal nerve pain, LGBTQ community, especially our transgender community. So that is between the gender confirmation surgeries, which typically the surgeon has a protocol for them to follow. And they do send them to pelvic floor therapy. However, some do not, which is a crime. Like truly, it's a crime. It's horrible. Body modifications as well. So things like binding, tucking, packing can all affect your diaphragm, your core, your pelvic floor, and disrupt your bowel and bladder and sexual functions. Pregnancy, postpartum, that is a huge one that like everyone knows about, right? So that's a really that's honestly my bread and butter. I love working with the pregnancy and postpartum population because I am so close to that part at this point. And it's also really cool because you having the background in infancy as well, it's easy to combine everything and make sure that mom and baby are being taken care of. But things like back pain, hip pain, pelvic pain, waddling during pregnancy, not normal. Like there's so many things that are just not normal. They're common, but they're not normal. Incontinence during pregnancy that are just brushed off because they're pregnant. Pediatrics. So this is one that is not as common. I do not actually know anybody other than CHOP, like Children's Hospital of Philadelphia, who is doing pediatric pelvic floor therapy there in my area, in the Philadelphia area. There is a clinic in, I want to say USC, I want to say it's in California, in LA, where the OTs actually run the entire clinic, and it's called like the toileting clinic or something like that. They don't call it pelvic floor therapy, which I'm like, no, call it that, like call it what it is. But they've been doing it for years and years. So it's not new, but it's niche, right? So pediatrics was one that I realized was a huge gap in our area. And I have a lot of friends with toddlers right now who their doctors are prescribing the kiddos Miralax like weekly because they just constantly need it. And that's it. Miralax is something that's not FDA approved for children. It's just, can have neurological effects. It can cause seizures. It can cause behavioral issues. It's not a nice thing to give to toddlers. And oftentimes that's just masking the problem, right? That's like having chronic back pain, taking ibuprofen for it. It's not going to setting. So lots of chronic constipation, bedwetting or daytime accidents after a certain age, incontinence. Teenage girls especially are known for something called giggle incontinence, where they literally will be like at a party when they're 13 and laugh a little too hard and pee themselves. And so it can be really mentally an issue for them because just that, so like the social aspect of it is just heartbreaking. Neurodivergencies and sensory differences. So if kiddo doesn't have a ton of interoception, right? How is he going to tell when he can go to the bathroom or when he has to go to the bathroom? Especially if it's kiddo so my son who's 3 is autistic and he has such a hard time with figuring out when he has to go to the bathroom. He can sit on the toilet and he will pee because he knows how to push his pee out, but he will not, he has no clue when he has to go to the bathroom, either pee or poop. So it's definitely an issue when you have those sensory differences. And if they're going into kindergarten, something where the school is kind of pushing back on it, then it becomes a big issue, right? And oftentimes behavioral therapy is the thing that's thrown in there as the fixer, and that's not what they need, because that can often cause more trauma than anything. Usually it's more neurological and sensory than it is behavioral. And then men's health. I actually did not work in men's health. The closest I get is transgender health, because we work either way, but men's health, premature ejaculation, erectile dysfunction, tailbone, back, pelvic, hip pain, that's supposed to say testicular, not testibular, and post-prostatectomy, incontinence. So any of those things also are helpful with men's health. Okay, so literally everyone, right? Like everyone can benefit from this. Why does pelvic floor dysfunction happen? All of this, I'm not even going to go into, like, honestly, any aspect of your life can affect your pelvic floor, because your pelvic floor is truly the most, it holds emotion, it holds trauma, it holds memory. Not only that, but it is incredibly susceptible to anything happening to the hips, the pelvis, the back, the neck. Everything works down because the pelvic floor creates the bottom of your core. So anything that happens anywhere can affect the pelvic floor. Okay, and then this is just like a quick little anatomy portion. So this is kind of the pelvic floor anatomy. There's 14 muscles, forms a bowl, or I like to think of it more like a trampoline in the pelvic floor. And basically this trampoline, how I think of it is that the muscles make up the trampoline portion, right? The part that you jump on. If they are functioning well, you're going to go really high. It's going to be really fun. And that's it. It's going to function perfectly. The poles, right, are like the structure, the bones. So we need those poles in order to support the trampoline. We also need the springs, which are kind of like the ligaments all in here, right? There's a million ligaments and tendons and fascial tissues throughout the pelvic floor. Those are all the supporting structures as well. So those are like the springs. All of those things need to be functioning in order for the pelvic floor to function. The pelvic floor is not Kegels. It's not. If any of you follow my social media, you will know it is, I am like super anti-Kegel, because it's just not the thing to do. If our hips are not able to rotate, if our glutes are not turning on, if our habits are poor, it's all going to affect the pelvic floor in a really negative way. The functions of the pelvic floor include the 5 S's. So supporting your pelvic organs. For men, that's bladder, rectum, prostate. For women, it's uterus, bladder, rectum. And then it also acts as a sump pump. So it helps to pump blood and lymph back into the heart. There are lymph nodes throughout the pelvis. Sexual function, obviously, right? So it allows for any sort of penetration, anally, vaginally, as well as orgasm, insertion, endurance, right? Sphincter control, being able to pee, being able to poop, but also being able to control when that happens, how long it takes, and things like birthing a baby. So that's important too. And then stability. So there's 3 layers to the pelvic floor. Each layer has its own kind of functions, but they all work together in order to provide all of those functions. That's a lot of functions, though, that get ignored on a daily basis, right? So then some of the accessory things that I always look at include the diaphragm, the transversus abdominis, which is this gigantic muscle in here. It forms this natural back brace, and it's my favorite muscle in the whole body. The glutes, which, you know where those are. The lateral hip rotators, so back here. Glottis and jaw muscles are the other thing. So all of these things affect the pelvic floor in their own way, and it's amazing. So the diaphragm and the pelvic floor are kind of the most well-known and the most direct relationship. Diaphragm, TA, transversus abdominis, and the pelvic floor form your deep core. Your diaphragm and your pelvic floor only work together. They don't work apart. So if your lungs are filling up, your diaphragm is lowering and your pelvic floor is lowering. So if you're inhaling, your pelvic floor is going to relax because those muscles are lengthening. As soon as you exhale, everything's going to naturally tighten. We don't need to do things like Kegels to like extra strengthen that. And as you saw with all of these accessory structures, there's also research that shows that the pelvic floor, like doing a Kegel, only actually activates between 40 and 60% of your pelvic floor strength. So it's not much. This is why I work at a network. So I can't get this done, an evaluation like this done in an in-network clinic. It takes me 2 sessions when I was working in network to get everything done. However, all of this is incredibly important. I'm not going to read everything. The things that I want to touch on that OTs are amazing at, though, include going over mental health, screening for mental health and trauma, right? Looking for bodily cues, going over things like hobbies, activities, daily routines, because those are incredibly important for your pelvic floor. And then things like just reading people's cues throughout the session, right? Because the pelvic floor is an incredibly private area. Like I said before, it holds trauma, it holds emotion, it holds memory. This is an area and this is a specialty where you have to be trauma informed. There is no other option because you have 100% chance of working with someone who has had some sort of trauma. I just had a patient today who I evaluated who had gynecological trauma because the gynecologist just didn't even ask, just absolutely did a pap smear, did everything when she was 19 years old. He took a biopsy of her cervix without telling her, like things that should not be happening. And she was like, well, I was 19 and didn't know any better. And now she's 36. So now she knows that she can say no. But we are another person in that human's life who can tell them, who can show them, who can empower them to advocate for themselves, right? Especially when it comes to this stuff. So teaching them things like, I ask for consent at least 3 times before performing an intravaginal assessment, at least 3 times during the initial intake. And then I do an external assessment. We do functional movement. That's what I want to see. I ask before the external pelvic floor assessment where I'm looking at the skin, everything like that. And then I ask right before I do any sort of internal. I even ask you, especially if it's somebody with trauma, before I hit each layer of the pelvic floor. So things like that, OTs excel at, right? Like that is just, it's so OT. And these are all the treatment techniques that I use. So yes, it takes a lot more training than like, you know, just being able to like hop into, I mean, any job takes more training than, you know, but you need a lot of specialty courses for sure. Myofascial release is a huge one. Vagal nerve training is another big one. Just knowing the modality, treatment, and recommendations. Medical techniques. So I do need to learn a lot about like what kind of injections are beneficial for helping with, you know, pelvic floor tightness, or what kind of hormonal medications might have this effect on people. Lots of activity modification, bowel and bladder diaries, meditation, mindfulness. Some people do biofeedback. I don't, because I don't find it useful, except for in pediatrics, because they can't really, you're not doing internal with pediatrics and they can't tell you things. So then it's helpful. But lots of strengthening exercises, habit stacking. I'm a huge fan of, especially with the moms, the new moms, or the overwhelmed people in general. Hey, can you do a home exercise program? If they say no, or if they say, I mean, I can try, it's not going to happen. So not only is it not going to happen, I'm going to be a source of guilt for that person, because that person is then going to go home, not be able to do it and feel bad about it, possibly cancel their next session because they didn't do it. And then where did we get? Nowhere. So what I like to do is say things like, hey, how much do you clench your glutes? And they're like, I don't know. And I'm like, okay, that's your homework. Figure out how much you're squeezing your butt all day. And every time you go and fill your water bottle at the fridge, I want you to unclench your butt and take 5 diaphragmatic breaths. And it works wonders, because then that follows them through life and they don't have to come back to me. And that's the goal, right? Is to teach them about their own bodies so they don't have to see anyone anymore. What else? Oh, these are just some in action, some pretty pictures. So internal looks like this. I literally sit on the table with someone. This one was breastfeeding baby, and literally just do internal. This is one of my therapists doing some breastfeeding education with, like, you know, biomechanics, any sort of modifications that we can do using a pillow like that, dropping the shoulder, not like tightening the neck. Manual therapy, so lots of like C-section scar massage you can see there. She's doing education, so like using a mirror. She's doing exercises, and birth prep is another huge one that we can do. We can help reduce C-section rates, we can help improve VBAC rates, we can help reduce perineal tearing, we can help with any sort of scar management. It's pretty amazing. And then really, why do OTs excel in this specialty? The short answer is because the pelvic floor dysfunction is never solely an orthopedic issue. Pelvic floor therapy is often referred to as pelvic PT or pelvic floor PT or whatever. We're trying to change the vernacular to make it pelvic floor therapy or pelvic OT PT, pelvic PT OT. I don't really care. Just, you know, something inclusive, right? But the real thing is that I find that OTs, and I've mentored at this point 30 OTs who all have their own businesses or are working in clinics, and the amount that OTs are able to bring in their new information from the courses that they learn and just immediately apply it like a absolute badass OT would is amazing, because we just make the biggest differences in our patients' lives instead of just being an ortho mill, right? Like, it's not, and I'm not bashing any, I really am not. It's just truly the OT lens makes sense. And it makes much more sense in this because it is functional. It's not orthopedic. In order to treat the pelvic floor, you have to take into account the person as a whole. If they're a high anxiety person and they speak like I do, like they speak really quickly, or they speak even faster than I do, likely they're going to have a tight pelvic floor, right? Like, that's just kind of, you can tell, but you have to take that stuff into account. That's it. And then there's my little, like, if you want to scan a QR code or anything like that, for my Instagram, and that's my clinic stuff. So yeah, let me know when to stop sharing, because I do want to, oh, thanks guys.
Yeah, sure. Danika, if you want to stop sharing so we could all see each other's faces before the Q&A portion.
Yeah,
thank you so much for that presentation. That I'm one of the people, I've been following you on Instagram for a long time now. And so when I found out like that you coming to speak and you on Instagram are the same person, I was very excited. So thanks again for being here. Your presentation was amazing. I have so many thoughts and questions in my head, but I want to see if anybody has any questions for Danika. Emily Kwan, start us off.
Yeah. I do have a question. I'm really curious about how you talked about pediatric constipation. I'm on my specialty field right now, and I'm part of an interdisciplinary team on a feeding disorders clinic. And one of the main things that we always come across is constipation with our kiddos. And I was wondering, because our physician in our team, first thing she's always going to say is, are they on Miralax? So I was just wondering, what can I suggest instead?
So a lot of pediatric constipation stems from a few different things. So it can stem, obviously, an eval is really helpful, but let's take my 3-year-old. It stems from poor core strength. So his diaphragm is not working that well. He was speech delayed. So there's all of these, blocks that fall together. these things that just snowball, right? So poor core strength, poor diaphragm use. If the diaphragm is directly connected to the pelvic floor and your child is late speaking, or they are nonverbal, or they just have a really breathy voice, or they're really not taking deep breaths or able to maintain positions and extension, right? Then we're going to see more pelvic floor issues. That's more the musculoskeletal piece. If their sensory aspect is not there as well, you're likely going to see this kind of mashed together as this chronic constipation issue. So if it's kind of the perfect storm of like musculoskeletal overall kind of weakness, and if picky eating, if nutrition is an issue as well, if there are nutritional deficits, of course, that's going to affect it too. If kid is not into eating fiber, I mean, which honestly, what toddler is, but if they're not, that's going to be an impact, but everything else is also going to be impactful. So we do a lot with like books about like, oh, how does my body feel, and how do lots of blowing activities, lots of things to get those deep breaths and like get them to really blow through straw. Can you keep the feather up in the air as long as you can? Things like lying in prone and just doing, scooter board or coloring or doing whatever they want, but in prone, because prone for anyone, you get a better diaphragmatic breath. So just like in actually respiratory cases, like in the hospital, if you're in those really bad COVID cases and stuff, you saw like people are in prone, that's because your diaphragm will literally work better in prone. So we can build the strength because the diaphragm is a skeletal muscle. It builds strength, it builds mobility. So we can build the strength by doing things in prone. You can even literally just tie a sweatshirt around a person, whether it's a kid or an adult, around the bottom of their ribs and have them breathe into that. That's a really good tactile kind of feedback. Like it gives a little bit of proprioception. Kids love it. They think it's hilarious. So yeah, like those are kind of the aspects that we often look at.
Yeah, that's super helpful. It all makes sense to me. So that's great. I'm going to talk about that with my team.
Good. I love it. OBs. Sorry, I'm reading the message from Sherry. So literally my OB told me at my 6 weeks postpartum, just do the Kegels and you'll be good. Luckily, I knew better thanks to you and your Instagram. I love that. Because Kegels suck. Like I said in multiple times, like honestly, I don't know what it is about Kegels. It was created, and here I am going on my damn hill that I will die on, but it was created by a man. It was created by, hey Sherry, hi sweet thing, hi. I'm so proud of you for not doing Kegels and for birthing that baby. You go girl. But yeah, like we do not need to do them. They are basically, if you're giving somebody bicep curls to do as an exercise to strengthen their arm, right? Like it's going to strengthen their arm, but it's also a natural movement we do. We do things like picking things up using elbow flexion. It makes sense. Kegels don't happen naturally. So why is it this obsession with Kegels in the women's health world that they think it's going to fix everything? If your pelvic floor is too tight, it's going to make it worse. So Kegels can often make a lot of issues worse, including incontinence, pelvic pain. I've had OBs. I'm not bashing OBs. They're the typical women's health people. I've had people tell women to do Kegels after they're like, oh, I'm having pain with sex. I'm sorry, you're telling women to tighten their already tight muscles and just drug themselves with alcohol to be able to tolerate sex? Like, come on, guys, come on. That's not normal. Do C-section moms also benefit from pelvic floor therapy? Heck yes, honestly. It depends. Sometimes C-section moms can benefit even more. First of all, you still went through pregnancy. So that in and of itself is definitely going to affect your pelvic floor. C-section scars also are known to adhere to organs underneath, especially if it's a traumatic C-section or emergency C-section. So, or if you went through labor and then had to have a C-section, right? Like if you go through labor and you are pushing for 4 hours and they call it and they're like, nope, you're having a C-section, you're still, I mean, you basically went through birth and then you had a C-section. So like, yes, C-section moms, absolutely, because you still had the same pregnancy, everything, and then just the baby was born out of the sunroof, and that is just as deserving as pelvic floor therapy as a vaginal birth is.
Any other questions that people have either on Zoom here through the video or in the chat? Feel free to keep asking away.
I have a question. First of all, thank you so much. That was amazing. I have so many questions, so this is probably going to be a little rambly and not cohesive. But you mentioned something about being out of network. And so I was just wondering, like, obviously every person can benefit from pelvic floor therapy, and it seems so amazing. And every person can benefit from OT, and the way our healthcare system works, so many people don't have access to either or both in this case. And so I was just wondering, you mentioned there's a lot of trends and pelvic floor therapy is becoming a little bit more common, I suppose. Do you see any trends to it becoming more widely accessible to people that might be on Medicaid or more publicly funded insurance programs that wouldn't have access to you out of network?
In good ways and bad ways, yes. So I will say my clinic, because I went to Ithaca. I feel like we all have those same like values and missions. So one of the things that my clinic does is 10% of all of our profits go into a sliding scale fund, and a pro bono fund, so that we can provide sliding scale and pro bono for anybody who has Medicaid or is just having financial issues, right? Because that should never be a barrier to quality care. With patients who, the issue is that one, patients don't know pelvic floor therapy exists. So especially in communities that are underfunded, in communities that are not as educated, it's difficult to get them to even come, because they are just like, no, I don't have time, I don't have money. And it makes sense. I mean, it totally makes sense. But it's also something that their providers, their primary providers, do not push on them, even if they have had the most traumatic issues. It just doesn't happen. If they do go, they tend to go to the clinics like, the big name clinics that have like a lot of ortho and stuff like that, which can be problematic for several reasons. So one is that a lot of the therapists there will take the first like Herman and Wallace course and be like, cool, I'm a pelvic floor therapist now. And it's like, no. Let's take more courses. You now know how to do an evaluation on a pelvic floor, and that is it. So, but the clinics will not pay for any more for like, another year. So then they'll basically say, oh yeah, we have pelvic floor therapy. And then the patient gets in there and they are not provided with quality pelvic floor therapy, because guess what? Their pelvic floor therapist is undereducated. So this is where I see a lot of patients coming to me after 6 months of pelvic floor therapy and no progress, which is like hard to do, to be honest. It's hard to do. Usually I get patients out in 5 to 8 visits. It's it. And so that is a difficult thing, because then a lot of them endure trauma from their pelvic floor therapist, which is also not a good thing because nobody's trauma informed. It's a whole. So yes, I do see it becoming more widely spread, but it's also not in the best way yet, which really sucks. And that's also a reason why we do a lot with like funding. Like I'm do like my clinic and another concierge physician clinic are doing a vino and vagines night where we like literally are providing wine and charcuterie and chatting with 20 women about women's healthcare, and all the proceeds are going into our sliding scale fund. So we are very passionate about that part. But yeah, it's a huge issue for sure with being out of network in general. And most clinics don't do that.
Thank you for explaining that and echoing in the chat and reactions. Thank you for your dedication to making it accessible. You're amazing.
Oh, absolutely.
You.
I wish I was in Ithaca too. I miss Ithaca. I don't like Philadelphia. I like it, but it's not outdoorsy enough. Anyways.
I want to jump in quick. Well, you always have a home here, so come back. But I want to say that I know there has been a lot of talk and trend in the profession about this topic, and again, OT should do it. And unfortunately, a lot of times it's because, well, PT is doing it, so we should do it. And I can't tell you how proud I am. I mean, I had no doubt that when I looked at your website and heard what you're doing, that you would be 100% occupation-based. This is what we need to be doing in this realm. We do not just need to be doing, the biomechanical approach. And I'm just so thrilled that you're doing this work and doing it in such a passionate and amazing and inclusive way, right? You just make us so proud. And this is what OT's role really needs to be, right? About social participation in work. I mean, and the things that OTs do, like this is our distinct value. So I'm just so proud of you. Come back to Ithaca and bring this here. And I mean, keep doing the good work. And I just want you to get this information around to train other OTs on this so that we can get away from that model of reductionistic, biomechanical, and really look at the whole person. So just, huge kudos to you, and we're so proud of you.
Thank you. It has definitely been a few years of figuring out, am I allowed to do this? Is this what I'm allowed to do? And then finally finding a few other OTs doing it and being like, yes, we're gonna take this by storm. And honestly, I mean, if you look on Facebook, there's an OTs and pelvic health group. It has thousands of people in it, which is amazing. And there's pelvic health OTs courses now. So like literally by occupational therapists who have been in the field for longer than I have. And the field is just becoming super awesome and super strong. And it's like the passion, because honestly, if you're not passionate about pelvic floor, you're not going to work in it, right? Like if you don't want to work with incontinence or talk about bowel health all the time, like it's not something that you're like, I'm just going to go into this because it's a moneymaker. Like, no, you really have to be passionate. So it's been an absolute, like, it's just been such a cool experience finding this passion and being able to just go with it and just getting in at the right time that, I've been able to help mentor other OTs. I've been able to start a business and employ 2 other OTs. Like, what? That's amazing. So just the fact that OT is getting more into this, now we just need to keep fighting for like AOTA to recognize it, and because that's really where our struggles are, is that there's just there's not much of a fight going on up at the top, right? It's like a grassroots campaign. It's very
start somewhere, so you're making an impact.
Yes. But
Awesome.
thank you, Julie.
Yeah.
Any other question? Oh wait, there was another.
Yeah, there's some more in the chat. Lauren said, can you touch on pelvis floor for women with hysterectomy? I'm curious how this affects the pelvis. This whole presentation has been so interesting. Thank you.
Yeah. So hysterectomy. So basically, it's typically laparoscopic surgery. So it's not a huge incision or anything like that, but the incisional sites can still create a lot of adhesions into the tissue beneath them. Sorry. The other thing is that it is literally a weight lifted off your vagina. So there's nothing weighing the vaginal canal down. There's nothing there anymore. So it can make a huge difference in the pelvic floor musculature, because all of a sudden that pelvic floor can kind of like spring up in being like, oh, like there's nothing here. Let me just tighten up a little bit. And so a lot of times people who have hysterectomies can have a lot of pain with sex or just general incisional pain, things like that. So we tend to, there's no like pre-op really needed unless you're having bound bladder dysfunction. But with taking an entire organ out of your body, there's going to be some functional differences. So it can also affect the bladder because sometimes the uterus will kind of sit on the bladder. So like it'll affect that. It can also affect the rectum. You can notice more diarrhea. You can notice because there's nothing like pushing against the rectum. So it can affect a good amount of things. So it's just kind of a like post-op is just a good idea to go get evaluated. And then what else? What are your recommendations for getting started in this specialty? So lots of things. So definitely taking courses. Honestly, social media is amazing. It is phenomenal at teaching us things. I learn things on social media every day from other pelvic floor therapists, from PTs, from OTs, from speech paths, from everyone. So looking up pelvic floor therapists, there's a lot of pelvic floor OTs on Instagram, which is awesome. So that is a huge piece. And then also taking the courses. So there's the two courses that are OT driven are OT Pioneers and PRMAT, which has a longer name, Physical Rehabilitation Manual Assessment Tech. I don't know, it's something. But those two are the OT courses. And then Herman and Wallace Pelvic Rehabilitation Institute is kind of the big name. Like they have all the courses you could possibly need. Just keep in mind, they are very PT driven. So all of their courses, you're going to feel a little like, what is going on? Because it's all very PT based. However, if you're more like orthopedically minded and you're more like it works really well, to be honest. And things that they were talking about in Herman and Wallace, after the first course, it was really easy to grasp. And then the second course, actually, Julie, Mindy, I don't know if you guys remember Katie Ahart, but she took it with me because she also does pelvic floor therapy. And so we took it together and we were like, this is so OT because it was all colorectal. It was all like habits and routines and all of these things. So it just gets easier as you take the courses because you just get more confidence and you learn more. But yeah, definitely following people. And then usually a mentorship of some sort is recommended just because it is so specialized. Doesn't have to be with me, but there are several people who mentor in the pelvic health field, and it is really helpful because it can be a little scary when you're starting. Like it's one of those that feels a little like, am I supposed to do this? So definitely those three things. Oh yay, Katie was my level 2. I love that. Katie is wonderful. she's one of my besties. She was amazing. Any other questions?
I have a question.
Yeah.
So I know you were talking about like on your first few slides, like so like there's so much that there's so much that you can do and just so much and so many different populations. And I know like me from like standing at an uneducated standpoint of just how much pelvic floor can be and can do. I was wondering like, how do you see that there's a lot of people who like may not be the people you typically think of that would be getting pelvic floor therapy, knowing about your practice and coming in? I know you mentioned the giggle incontinence. To me, I would never think, oh, if that's happening to me, I should go get pelvic floor therapy. So how do you see people like finding out about pelvic floor therapy and that it's even a thing that they can go to?
It's a hard thing. So it's more common now than like ever before, truly ever before, but it is still so many things are just put on the back burner, especially when it comes to women, because we are super good at just dismissing our concerns and being like, I got other shit to worry about. And it shouldn't be that way, but it is. So people finding out about pelvic floor therapy comes from a number of different directions, but honestly, the biggest thing is word of mouth. So just being open about it and being like, oh yeah, I was at my pelvic floor therapist last week and blah, blah, blah. And then somebody's like, pelvic floor therapist, what were you there for? Which is a little bit of a rude question, but whatever. And then they're like, oh, well, I don't know, I have fecal smearing. When I wipe, it wipes like a marker. It just won't stop. And they're like, that's what you go to pelvic floor therapy for? And they're like, yeah, I also have hemorrhoids and like, those aren't normal. So, you know, they're fixing it. And then it's like, oh shit, well, what else isn't normal? And then people Google it and then it just kind of blows up from there. But all in all, a lot of word of mouth, social media, people will be like, you know what? I found it on TikTok. And then I Googled in my area, like pelvic floor therapy, and I found your clinic. I'm like, okay. Sounds good. That's what it takes. And then it also like, it'll be random people, right? So I was treating for a while. I had a labor and delivery nurse from like the biggest hospital near me who does maternity care. Hey, so she was, hey, sorry, my husband. So she was great because she is basically putting me in touch with the hospital people to be like, hey, can we put some paperwork into the postpartum folder that every new birthing person gets, and basically stating like, hey, if you're having any of these issues, you should go see a pelvic floor therapist. So it's really trying to get into systems and reworking them and including them in there. Unfortunately, things like OBs, big practices tend to gatekeep their providers. So like if I go into there, I have to provide lunch, which I'm like, okay, but I'm a small business and you're literally taking any of our extra money goes to our sliding scale and pro bono. So like you're taking money from people who need it more than you. So like, can you just let me talk to you? Don't you want to learn more about how we can help your patients? Don't you want to learn more about when to refer your patients? So hopefully doctors are learning that more. And then I also tell my patients all the time to, if they go to their doctor, tell them about it, because we have to get a script anyways. So they know that they're going, but they forget. They just sign it and fax it. Tell them about us. Say, hey, listen, I'm seeing Danika and she fixed my incontinence in 3 sessions. So like if you're having anyone with incontinence, you need to send them because to a pelvic floor therapist, because it's vital and it's important. And there's statistics that show like even with postpartum incontinence, if you have incontinence at 3 months postpartum, you have a 76% chance of having it at 12 years postpartum. And if you have incontinence, give me 1 second to pull this fact out of my brain. So if you have stress urinary incontinence at 3 months postpartum, you have a 46 or 44% chance of also having postpartum depression. And they have found that there is they like correlate with each other because your function is off. So it's not a direct thing. You're not obviously having postpartum depression because you're incontinent, but they correlate very strongly, which also, I mean, how OT is that? Like, come on. So looking at the big picture, right? So times like that, that's when you talk to mental health therapists and you're like, hey, if you're seeing anyone with postpartum depression, ask about their pelvic floor, which is silly, but like truly ask about their functions, because if they need to see somebody else, that's something that they need a referral for. So referrals are very difficult to try and track down, and it's really hard to figure out when you need to see a pelvic floor therapist is what I'm trying to say. But it's something that between social media, Google, hopefully providers are kind of learning more. And then even things like this, like if one of these people goes to their mom and is like, hey, did you know, I know you've been leaking for like 30 years, but did you know that that's not normal? She tells her friends, and then all of a sudden 6 more people know. Talk about it. That's really
Cool. Thank you so much. So I want to respect everybody's time, and we are just about at 8 o'clock. But Danika, maybe if you could put the contact info that you had on your
yeah, sure,
in the chat for people if they need it. thank you so much for coming and talking to us. It was really so amazing.
You're so welcome. Thanks, guys.
Thanks so much.
Mwah.
Reminder to everyone that the transcript and recording will be posted and provided. And then our next speaker series event is with Rachel Ashkenazi on November 16th on international work in Israel. So stay posted for that. So thank you so much to everyone for coming. Danika, thank you once again. It was really
so welcome.
so amazing.
Yay. I'm so glad you guys loved it. And if anybody is interested in pelvic floor, don't hesitate to reach out, email, Instagram, anything. So yeah.
Love it. Thank